This lecture describes the nursing process, the 5-step systematic process for creating a nursing care plan for a patient. It's key that we do this in a systematic, problem-solving way so that we aren't skipping essential aspects of our patient or their symptoms or their holistic self in a sense. It's also essential that nursing partner with their patients, we call them patients in a hospital and clients when they're not hospitalized, in order to come together to agree on their need for nursing care. And it can't be something that nursing is doing to patients, but it must be something that nursing is doing for patients or clients. And so that's why we need their input into what they consider their biggest concerns. We also want them to help determine goals and outcomes, to talk to us about how best to implement the care for them, and certainly we'll be talking to them about how to evaluate the results of their nursing care. So a key part of the nursing process that I want you to understand is that it's client-centered. It must also be goal-oriented. We don't do anything to patients or clients without a goal in mind. So the process, sometimes it's depicted as a circle. The acronym for the nursing process is ADPI, and you can see this on the screen: assessment, diagnosis, planning, which is really that determining the goals, interventions. Intervention, that word implies nursing action, and then evaluating how successful it was. And it could be that in the evaluation it is determined that the goals were not met and that you would begin this again. And so that's why they frequently show this as in a cyclic fashion, because we're assessing patients and determining their problems on an ongoing basis. Assessment is always the first step of the nursing process. And I usually use the analogy of CPR. If you've had to take CPR, what are the first things that you do? If we were to step outside the classroom and see a student down on the ground, what would we begin to do? And of course we know we're going to notify someone to come for help and bring the defibrillator and so on and so forth, but in our actual dealing with the person down, the patient on the ground, we would do what? We would shake and shout, right? Because we're assessing. And there's no way we'd jump ahead and start actually doing things to them and blowing in their mouth and jumping on their chest or shocking them or whatever until we began to assess. So since you've all had the experience of taking CPR, I use that as an analogy for you. Assessment, and then once again there's that word systematic. We have to be organized so we're not skipping major sections of our patient and missing major clues about what might be wrong with them. Before we begin assessment, we first have to ask ourselves, all right, and so who is my client? Is it a single individual? Is it one person? Maybe it's a family. When you're dealing with a pediatric patient with a child, you have to encompass the entire family and bring everyone's resources to bear on that child. Maybe it's a whole community. You know, example given is the salmonella outbreak that we had this particular summer with tomatoes, but it could be an entire community that we would be analyzing and assessing. So what kind of information are we actually looking for in our assessment? Well, nursing is holistic, meaning we look at the whole person, the whole family, the whole community. So in addition to physical information, we're going to concern ourselves with psychological factors and mood or emotional factors. We're going to look at social, cultural phenomena that may affect the person. And we do actually look at spiritual factors. There are multiple ways of organizing assessment data in order to know that you are indeed being systematic. And one is known as a functional assessment strategy. And a functional assessment strategy, Gordon is the famous nursing theorist who's created the functional assessment. You can see it in your text. And we look at how is the person from a sleep rest standpoint, how is a person from a mobility and movement standpoint. So it's these kinds of actual human functioning that are looked at. Another way of looking at a patient is to do what's called the review of body systems. In a review of body systems, data is gathered around specific body systems. So, you know, cardiac, respiratory, gastrointestinal, and I don't ask that you memorize either of these. What I would like you to do is when we go into the hospital and we see the computer screen that's looking at the assessment data we need to collect, or we look at the hard copy, that you be able to look and recognize, oh, I'm going to be doing a functional assessment, or this is a review of our body systems. What are the methods of assessment? How does nursing collect the data that they use to make a nursing diagnosis? Clearly, you're using all of your senses, whether it's vision or smell or hearing or touch. Interviewing refers to the ability to use therapeutic communication to speak with a patient. And some questions that we put to patients are considered screening questions. So these are very broad questions. What brings you here today? What is your main concern? Are there concerns about your health I haven't addressed? Those are sort of very broad questions to begin to create a relationship with a patient, establish trust, and open a place where they can now begin to talk to us about their health concerns. Focus questioning is when now the questions are much more targeted on the patient's response to zero in on some of the data that they've given us. We will also be using physical examination techniques, and those will be covered in your health. Actually, everything on this slide you'll be looking at in your health and physical assessment class. But the 4 physical assessment techniques are inspection, which simply means to look, to observe. Palpation. Palpation refers to touching a patient. Gee, is that swollen? Is their skin hot in that area? So palpation. Percussion is actually a technique of tapping to solicit sound so that you can determine, are the organs that should sound hollow and filled with air, are they actually sounding that way? Or do we in fact find that we're hearing noises that would indicate there's some solidarity under there, maybe liquid or tumor, etc. And auscultate means to listen, and in actual fact auscultation generally applies to using a stethoscope. And these are all the techniques you'll be learning and practicing in health assessment. There are many methods of knowing, and one of the methods of knowing is intuition. And after discussing the theoretical basis for nursing and evidence base in the research, it's hard to imagine that we would, at this point, be talking about gut feelings. But in actual fact, if you know much about neurobiology, they're coming out with a lot of information that quote-unquote gut feelings may actually be early indicators of mental activity where you're being able to recognize things before your mind does. And once you become more expert in nursing, it really is kind of interesting that you can look at a client and you can get a gut feeling that they're deteriorating maybe before you're actually seeing the signs and symptoms that validate that particular sense that you're having. An additional way to look at the data we'll be collecting is to separate out what is subjective data and what is objective data. Subjective data is what the subject says. So it's the client's own actual statements. And when we're documenting these, we write these in quotes. And we don't generally paraphrase what patients are saying, and we don't put words in their mouth. We say what they themselves have actually quoted to us. And this is the best, it's the best way to know what a patient is feeling or complaining of, is to hear it from them, and we actually do write down their own words. Secondary sources of subjective information are relatives, for example. And this is true in the case of pediatric patients. We often interview the family because, how can a 4-month-old tell you everything it's feeling or the behaviors or signs and symptoms it's been displaying? But we also do use secondary sources for subjective data for adult patients who are unconscious, for example, who are mentally handicapped, or in emergency situations when they cannot talk on their own behalf. And these specific sources that we're referring to are when we use family members or significant others. Sometimes we have other healthcare providers, other physicians, other nurses, etc. We do, in fact, examine their health records for prior health history, and occasionally we actually have to review the literature to know more about diseases they may have if we are less familiar. The other large category of sources of data are objective data. And in objective data, these are things that we can see or measure, but aren't the spoken word of the patient. So this would encompass laboratory tests, x-ray findings, for example, vital signs which we measure, and all of the data that we have collected through our physical assessment findings. Those would all go under objective data. And we use subjective and objective data to determine what we formulate as a hypothesis for what their nursing diagnosis might be. The first step is to look